is your student nurse Lhester. For today's video, I'll be making a new video, and that video that I will be making will be all about testicular cancer. Disclaimer, this video is for learning purposes only. So, let's go.
So, testicular cancer. Cancer is defined as a disease process whereby cells proliferate abnormally, ignoring growth-regulating signals in the environment surrounding the cell, according to Brunner and Sudar. So, testicular cancer. Before we delve into our discussion, we will tackle all of the introduction, overview of the male reproductive system, definition, risk factors, pathophysiology, clinical manifestation, assessment and diagnosis, laboratory and diagnostic procedures, management such as medical, pharmacological, and surgical management, nursing diagnosis, nursing management or responsibility, and last is the prognosis. So, cancer of testes are relatively rare cancer, accounting for approximately 1% cancer in males. And testicular cancer occurs when abnormal cells and testicles divide and grow uncontrolled, and it is highly treatable and usually curable form of cancer. The cure rate is more than 90% of all ages. So, overview of the anatomy of the male reproductive system. The structures in the male reproductive system include the external male genitalia, consisting of testis, epididymis, scrotum, and penis. The internal male genitalia, consisting of vas deferens or the ductus deferens, ejaculatory duct, and prostatic and membranous sections of the urethra, seminal vesicles, and certain accessory glands such as prostate gland and Cooper glands, also known as bulbourethral glands. So, testes, a pair of male reproductive glands located at the scrotum and covered by the tunica albuginea or the white fibrous layer, and responsible for producing sperm for reproduction and the male sex hormone testosterone. The testis is a homologous with the ovary in female, and it lies obliquely within the scrotum, suspended by spermatic cord, and the left testis is slightly lower than the right. And the shape of the testis is oval, and it has size of 3.75 cm long, 2.5 cm broad, and 1.8 cm thick. And it weighs about 10 to 15 grams. And it has 2 poles, 2 surfaces, and 2 borders. The coverings of testis are the skin, dartos muscle, external spermatic fascia, cremasteric muscle, internal spermatic fascia, tunica vaginalis, and the tunica albuginea. So, the structure of testis has 200 to 300 lobules, and each lobule has 2 to 3 seminiferous tubules. Each seminiferous tubules lined by cell in different stages of spermatogenesis. And among seminiferous tubules are sertatory cells. And between loops of the seminiferous tubules are interstitial cells produce testosterone. And the seminiferous tubules join to form 20 to 30 straight lobules. The right testis network of tubules located in the hilum of the testicles or in the mediastinum testis that carries sperm from the seminiferous tubules to the efferent ducts. And the right testis gives rise to 12 to 30 efferent ductules. And the epididymis, tube about 20 feet long that is coiled on the posterior surface of each testis, connect efferent duct to vas deferens. And the ductus deferens extends from epididymis in the scrotum on its own side into the abdominal cavity through inguinal canal. So, testicular cancer defines as a malignant tumor of the male sex organ or the testicles that normally produces the hormone testosterone. It is one of the most common cancers in young men. And most testicular cancers are found by men themselves as lumps in the testicles. The risk of testicular cancer is increased in males whose testicles did not move down normally into the scrotum during childhood or the undescended testicles. The etiology of testicular cancer is developed in one or both testicles, more commonly in right testicles rather than left testicles, and the exact etiologic factors is unknown. So the risk factors of testicular cancer are age, undescended testicles or cryptorchidism, family history, and other predisposing factors include orchitis and HIV. So the predisposing factors are the cryptorchidism, Klinefelter syndrome, positive family history, positive personal history, intratabular germ cell neoplasia, trauma, viral infection, hormonal factors, exposure to environmental estrogen. So in fetal stage, in primordial germ cell, KIT or KIT ligand or the stem cell factor or cytokine that binds the CIKT is a essential kinase that regulates of survival, cell survival and proliferation, hematopoiesis, and stem cell maintenance with the help of SDF1 or CXCR4 that forms a gonocyte, and there is an overexpression of stem cell genes or rest the gonocyte stage and gain chromosome 12p. And in preorbital stage, there is a intratabular germ cell neoplasia which is split into two, where there is gene mutation KIT or the KIT ligand and the TP53 or a tumor protein, and KRES as a protein that relays signals from outside the cell to the cell nucleus, and the NREAS or the neuroblastoma RES is a viral oncogene homologue. And there is a gain of chromosome 12p in the DNA hypomethylation. What is chromosome 12p? It is a extremely rare chromosomal disorder in which portion of short arm or the 12th chromosomal 12p appears 3 times rather than twice cells of the body. And there is a BREF gene mutation. That BREF is a human gene that encodes a protein called BRAF. That gene is also referred to a proto-oncogene BRAF or VRAF, murine sarcoma viral oncogene homologue B. And there is also an overexpression of pluripotent genes that gain a chromosome 12p and also causes DNA hypermethylation. And a post-pubertal stage, it results into a seminoma and embryonal carcinoma, where in the embryonal carcinoma there is multiple differentially expressed genes called as choriocarcinoma, yolk sac tumor, and teratoma. So therefore we call it a testicular cancer. So next is the classification of testicular tumors. The testicles contain several types of cells, each of which may develop into one or more types of cancer. The type of cancer cell determines the appropriate treatment and affects the prognosis. So testicular cancer is classified as germinal or non-germinal, germinal or stromal, or with the secondary testicular cancer may also occur. So germinal tumors. Germinal tumors make up approximately 90% of all cancers of the testes. So germinal tumors are further classified as seminomas or non-seminomas. These cancers grow from the germ cells that produce sperm, thus the name germinal tumors. So seminomas are slow-growing forms of testicular cancer that are usually found in men in their 30s and 40s. Although seminomas can spread to the lymph nodes, the cancer is usually localized in the testes. So seminoma, which has a serum alpha fetoprotein which is normal, and the beta HCG is elevated in 30% of the patients. And the classification is classical, anaplastic, and spermatocytic. And the classical or the typical has a percentage of 82 to 85%, which occurs in the middle age, which has a PLAP of 90% and syncotiotrophoblast, which is increase of HCG of 10% with a very slow growth. Other hand, a anaplastic is a 5 to 10 percentage to occur in the middle age and aggressive, and it is lethal. And greater mitotic activity, which has higher local invasion and higher metastatic potential, and it has a higher rate of beta HCG production. And the spermatocytic occurs in the old age greater than 50 years old, and it has a percentage of 2 to 12%, and it does not arise from ITGC, and it has a PLAP negative, and it's extremely low metastatic potential, and it has a good prognosis. So next is the germinal tumors. Non-seminomas are more common and tend to grow more quickly than seminomas. Non-seminomas are often made up of different cell types and are identified according to the cells in which these start to grow. So number 1 is the embryonal carcinoma. It's the second most common germ cell tumor, 90% of an SGCT. Present in majority in mixed germ cell tumors, most men present in their 20s or 30s with testicular mass, and highly malignant tumors may invade the cord structures or the epididymis and high degree of metastasis. So, what is an SGCT? A germ cell tumor that contain embryonal stem cells. These may be differentiated into extra-embryonic tissues or somatic elements. That is an SGCT. So, it has serum AFP is positive and beta HCG is elevated. Number 2 is a yolk sac tumor. Most often germ cell tumor in children, and it has 60% of GCT in children first 2 years of life, with a pure yolk sac tumor with less than 2% of testicular tumor in adults, and 40% of mixed germ cell tumors. Elevated serum levels of AFP and microscopically scalar Doval bodies are characteristic feature. So this is an example of this yolk sac tumor. And in yolk sac tumor, you will feel testicular mass. And the choriocarcinoma, it is rare and aggressive tumor, 5 years survival with a 5% rate. And typical elevated HCG, which present with disseminated disease with metastasized to the lungs and brain. And primary is a vet small and often exhibit new testicular enlargement. And there is a small palpable nodules is present and prone to hemorrhage, sometimes spontaneous, to the lungs and to the brain. Next is the teratoma, which from the Greek word tera, which means monster tumor. And it contains all 3 germ layers with varying degree of differentiation. Occur in its pure form on pediatric age group with a mean age of diagnosis at 20 months and mildly elevated AFP levels. So the non-germinal tumors account for less than 10% of testicular cancers. These cancers may develop into the supportive and hormone-producing tissues or the stroma of the testicles. The 2 main types of stromal tumors are Leydig cell tumors and the Sertoli cell tumors. Note, although these tumors are infrequently spread beyond the testicles, a small number of metastasize and tend to be resistant to chemotherapy and radiation. So, Leydig cell tumor may affect 20 to 60 years of age. A masculinizing tumor produces androgen and no association with cryptocardism, and presents with painless testicular mass, and also causes precocious puberty such as prominent external genitalia, deep masculinized voice, and pubic hair. and it also causes gynecomastia and decreased libido due to estrogen production by increased peripheral conversion. Next is the Sertoli cell tumor that can occur in any age group including infants and no association with cryptocardism. Then it has excess estrogen production that causes gynecomastia in 1/3 of the cases, and it has 10% malignant tumor. Last is the gonadoblastoma, which is a mixed germ cell 6-cord or stromal tumor composed of seminoma-like germ cell and Sertoli differentiation, and exclusively in patients with dysgenic gonads and intersect syndromes. And it has 80% are phenotype females with primary amenorrhea, and 20% are males with cytocardism and dysgenic gonads and hypospadias. And it is considered in situ malignant from GCT. And bilateral or chydectomy because of risk of bilateral tumors. So the secondary testicular tumors are those that have metastasized to the testicles from other organs. Lymphoma is the most common cause of secondary testicular cancer, and the cancer may also spread to the testicles from the prostate gland, lung, skin, kidney, and the other organs. So it's spread through direct spread, which occurs by invasion. Hall of testes involved are restricted. Tunica albuginea is rarely penetrated, may be crossed by blunder biopsy. Scrotal skin involvement, fungation on the anterior aspect, spread to spermatic cord and epididymis may occur that results in bad prognosis. And second is the lymphatic spread, which is a seminoma metastasized exclusively through lymphatics, and they drain primarily to the para-aortic lymph nodes, and from RPLN drain to systematicae or thoracic duct, then posterior mediastinum and left supraclavicular lymph. And from medial side of the testis run along the artery to vas to drain the nodes at the bifurcation of common iliac, and no inguinal nodes until scrotal skin involvement. And last is the blood spread, which is in SGCT spread through blood route. And lungs, liver, bones, and brain are the usual site involved. So the clinical manifestation of testicular cancer may have a slow, rapid onset depending on the type of tumor. The symptoms appear gradually as a mass or lump on the testicles and painless enlargement of the testis. And the patient may report heaviness in scrotum, inguinal area, or lower abdomen. Next is backache from retroperitoneal node extension or abdominal pain and weight loss. Next is the general weakness may result from metastasis. So the assessment and diagnostic findings are the history and physical examination, which involves the palpation of the scrotal contents, is the first step in diagnosing testicular cancer. Next is ultrasound of the testis. Next is the monthly TSA or the testicular self-examination is effective in determining testicular cancer. So TSE. So use both hands to palpate the testis. The normal testicles is smooth and uniform in consistency. So with the index and middle finger under the testis and the thumb on top, roll the testis gently in a horizontal plane between the thumb and fingers as shown in figure A. Then feel for any evidence of small lumps or abnormality. Next is to follow the same procedure and palpate upward along the testis as shown in the figure B. And locate and palpate the epididymis, a cord-like structure on the top and back of the testicles that stores the transferred sperm, and also locate the palpate the spermatic cord as shown in the figure C. And repeat the examination for the other testis, epididymis, and spermatic cord. It is normal to find that one testis is larger than the other. And last, if you find any evidence of small pea-like lump or if the testis is swollen, possibly from an infection or tumor, consult the physician. So the tumor markers are the alpha fetoprotein or the AFP in the beta human chorionic gonadotropin or the beta HCG may be elevated in the patients with testicular cancer. Tumor markers levels in the blood are used for diagnosis, staging, and monitoring the response to treatment. And also, blood chemistry is included, like the lactate dehydrogenase. It is so necessary in diagnosing testicular cancer. And also a chest x-ray to assess for metastasis in the lungs, and transcranial testicular ultrasounds will be performed, such as an inguinal orchiectomy is the standard way to establish the diagnosis of testicular cancer. And the other staging tests to determine the extent of the disease in the retroperitoneum, pelvis, and chest include an abdominal or pelvic CT and chest CT. If the abdominal CT or chest X-ray is abnormal, a brain MRI and bone scan may be obtained if indicated. And PET or the positron emission tomography is also used. And the medical management of testicular cancer is one of the most curable solid tumors is highly responsive to treatment. And the goal of treatment are to reduce the patient about the disease and achieve maximum care. The treatment selection is based on a cell type and the anatomic extent of the disease. And the treatment mainly include orchiectomy or a radical orchiectomy or the surgical removal of the affected testis, spermatic cord, and the regional lymph nodes. And retroperitoneal lymph nodes or the dissection or the RPLND may be performed after orchiectomy to prevent lymphatic spread of the cancer. So, other treatment modalities, radiation therapy is more effective with some seminomas than with non-seminomas. Post-operatively, radiation may be used in early stage seminomas. It is delivered only to the affected side, and the other testis is shielded from radiation to preserve fertility. So, other treatment modalities is a chemotherapy. It is used for seminomas, non-seminomas, and advanced metastatic disease. Cisplatin can be used as combination with other chemotherapeutic agents such as etoposide, bleomycin, paclitaxel, ifosfamide, and vinblastine. They result in a high percentage of complete remissions. With non-seminomas, aggressive surgical resection of all residual masses following chemotherapy is a standard therapy, and it depends on the stage or a type of cancer. And a patient with history of one testicular tumor has a great chance of developing subsequent tumors. Late relapse of testicular cancer is currently defined as tumor recurrence more than 2 years after complete remission following primary treatment that included chemotherapy. And the most common site of recurrence is the retroperitoneum. Follow-up studies include chest x-rays, excretory urography, radioimmunoassay of beta HCG and AFP levels, and examination of lymph nodes. And the nursing diagnosis of testicular cancer are the acute pain related to disease process, decompression or destruction of nerve tissues, infiltration of nerves or their vascular supply or obstruction of the nerve pathway, inflammation as evidenced by reports of pain. Next is the risk for infection related to inadequate secondary defenses and immunosuppression. Example given, bone marrow suppression, which is dose-limiting side effect of both chemotherapy and radiation, secondary to invasive procedure. Fear related to situational crisis or cancer, treat of death secondary to separation from family, hospitalization treatments, or interpersonal transmission and contagion of feelings. And the nursing management includes assessment of the patient's physical and psychological status and monitoring of the patient's response to and possible effects and surgery of chemotherapy and radiation therapy, and pre-operative and post-operative care. In addition, because of the patient may have difficulty coping with his condition, issues related to the body image and sexuality should be addressed. So, the patient may be required to endure a long course of therapy and will need encouragement to maintain a positive attitude. Once a patient's complete treatment, they enter a follow-up surveillance period. And a nurse educates these cancer survivors about the importance of adhering to the follow-up appointment for early detection of cancer recurrence. The nurse reminds the patient about the importance of performing TSE, or the testicular self-examination, is to perform once a month, and the test is neither difficult nor time-consuming. Convenient time is usually after a warm bath or shower when the scrotum is more relaxed, and the patient is encouraged to participate in healthy behaviors including smoking cessation, healthy diet, minimization of alcohol intake, and cancer screening activities. And most experts agree that couples should use birth control for 18 to 24 months after the last cycle of chemotherapy. So, lastly is the prognosis. So, the prognosis of testicular cancer usually can be cured if it is detected and treated early. However, this cancer can spread silently and quickly. This means that some men will not be diagnosed until the disease is an advanced stage. And at one time, testicular cancer could not be cured if it had spread beyond the testicles. Now, testicular cancer is one of the most curable cancers. Today's chemotherapies can shrink and eliminate the cancer cells that have spread to the other areas of the body. And if patients have been treated with either radiation or chemotherapy, they will need a lifelong follow-up for the potential development of these complications. So that's all. Thank you.
Thank you for watching, guys. I hope you learned something. And before I end this video, don't forget to like, share, subscribe, and hit the notification bell for more upcoming learning videos. See ya. Bye.